right, good morning, class. Today, I'm Tavian Harden, joined by
Jessica Castro.
we will be presenting on craniovertebral instability interventions. So, we've already briefed over what craniovertebral instability is. So today, we want to take you through some interventions.
The objective of today's session is to understand elements and phases of the rehab process of this type of injury. For problem number one, we have restricted neck movements, more like limitation to the neck flexion. In this stage, we focus more on training cervical and neck flexors, cervical flexors and extensors, which means that are the longus cola, longus capitis, rectus capitis, anterior and rectus capitis lateralis, which they are responsible for stabilizing the cervical spine. The neck extensors and flexors are muscles that control the head and neck movements, and they maintain a good posture on your body. For our max protection phase, we have the postural orientation for the patient and also perform chin taps to achieve the correct pattern of movement and train the flexor and extensor group muscles. For our mother protection phase, we have the strengthening of the global muscles. The global muscles are refer to the neck and spine, which are trapezius, sternocleidomastoid, spinatus capitis, spinatus cervix, and levator scapula. For that one, we decide to perform shoulder blade squeezes. And for the mid protection phase, where the patient's going to return to function, we decided to do a accurate head position and movement control. So for that one, we're going to need a chair. Can I borrow your chair? For the chin taps, you can do it on prone or sitting. I'm going to ask my patient to sit. What we're going to do is ask our patient to move our chin back, not down. So can you please move your chin back? What we can do is have 3 sets of 10 with 10-second holds, and the patient's going to perform that, so we can strengthen the extensors and flexors group muscle. All right. Then we have the other phase that is strengthening of the global muscles. What we're going to do is perform shoulder blade squeezes. Can I have you on the table for a little bit? For shoulder blade squeezes, I can ask my patient, I can put my hand in the middle of his back and ask the patient, like, can you try to squeeze my hand with your shoulders, please? We can do 3 sets of 10 as well with a 10-second hold. And that will strengthen more of the global muscles. And then for the last one, which is we're gonna assess the head position and head control. We can ask our patient to look over that window. Now, can you look to the door? Can you look to the ceiling? And now you can look to the floor. That's for the first problem. Then we have, here are some pictures, right? The second problem we have is decreased balance. For the max protection phase, we also put education and safety to the patient. And we have the one leg stand using the back of the chair for stabilization. This one can improve your balance, coordination, and posture. This exercise also strengthens the muscles in your lower back and lower body as well. And it will also improve the body awareness of the position in space. For the mud protection phase, we had some dynamic balance training. For that one, we're going to involve, it involves training on moving your body while standing on one or both legs, introducing pauses, holds, or any kind of uneven surfaces. We have the tandem stance on an uneven surface or with eyes closed. And for the mid protection phase, we have the patient going to return to regular function, and we have balance block with cones and creating an object, which this is more like a dual tasking training. For that one, I will ask my patient the first max phase to, you can use that one. Okay, very good. And then they can use the back of the chair as something to stabilize themselves. And then I'm gonna ask my patient to stand with one leg and not try to balance without touching the chair. The chair is just there for protection. In this situation, we can have a gait belt depending on how the balance of the patient is. Then for the second one, we have tandem on an uneven surface. I will use a pad here. And I'm gonna ask my patient to have one feet in front of the other, just like this. And balance. They can use the chair also to stabilize themselves. And another option is gonna be with eyes closed without the pad. Just like that. And for our last phase for this issue, we have balance walk with cones and carrying or balancing an object, which is, we're gonna explain that they're gonna walk through the cones and they're gonna have to balance an object, okay? So for this one, they're just gonna go through the cones, just going over the top of the cones, there you go. So I realized they're too big for this one, so let me put it shorter. All right, let's go. And that will be the third exercise for the mid protection phase. Pictures.
All right, so our next problem is strength. So the neck is oftentimes overlooked when it comes to strengthening. A lot of people don't really know how to strengthen the neck. But so for the max protection phase, we're just gonna educate the patient on how important it is to strengthen the neck since it's unstable. So for this mild protection phase, we're gonna do some resisted neck flexion and extension. We're gonna do some isometric holds. And then for the mid protection phase, the patient is just gonna increase. So we will progress from that. So we may use a lighter resistance band in the mod and then go to a higher resistance band. And then you figure out what the patient's occupation is. Maybe they're trying to return to sports or career, what have you. We have some examples of that. Here are some of the pictures here. So first I'm gonna show her one that she can do at home. So can I have you seated? So for the isometric hold that we have here, the right corner, can I have you place your hand on top of your head? I just want you to push into your hand, hold that for 5 seconds. Good. So roughly we would do this about 10 times. That feel uncomfortable or anything? Good. You want to make sure your patient is comfortable while they're doing that, no pain. Although we don't treat pain, we treat function. So here we have a resistance band that she can also do at home. Typically in the clinic, you may be able to cut some TheraBand and give it to him. You want to place his towel right here. I want you to resist against this band and look towards the ceiling. Relax. Roughly, I would do about 2 sets of 10 here. And then that was for extension, but now we're gonna do flexion. So this one may be a little difficult for her to do on her own, but she can tie it to a doorway or something. I'm gonna place this here. I'm just gonna add a little resistance, and I want you to tuck your chin, look down. Good. One more time. Good. Same thing, we do that about 2 to 10 times. And like I said, from here, we would progress into a larger resistance. And yeah, those are our interventions.
Yes. If someone has any questions? So how would the
determine when a patient is ready to progress to the next stage?
Well, as the exercise continue, we're gonna check on our patients. They need to demonstrate a proper, like movement patterns. They have good control of the muscles. They have good control of balance, and also like having good stability. Because like the exercises we show is more like stability and posture and strengthening. So once they achieve that goal, we can progress to the next phase.
I also want to add to that, you know, every phase has its own goal, right? So it may be inflammation for one patient. So once you get that down, then we may can move into more range of motion. Then once we have more range of motion, then we may can move into more strengthening. Or you can kill two birds with one stone. Sometimes strengthening goes along with the range of motion.
When you were doing tasks like walking over the cones and also holding an object, I guess like dual tasking, what populations would you say that's like best for?
Well, I'll start with like older adults. It will be preventing more like fall risk situations. Also for like athletes, it's gonna be more for strengthening and balance, so they can return to the sport. And like also you can use it for people that suffer Parkinson's, a stroke, or like neurological patients as well.
Since the minimum protection phase and the strengthening was education, as far as the mod, what would you say comes first, the isometric holds or just the light resistant flexion extension?
I would say isometric holds, only because I'm able to get all of the neck muscles involved. A lot of times with isolated movements, a patient may compensate and they may not target every muscle that I need them to get. So yeah, I would go isometric holds.
What is the difference between a chin tuck and just cervical retraction?
The chin tuck is, so the cue, so with the chin tuck, you are asking the patient just to strictly go back. But with cervical retraction, that's you said cervical retraction, I believe you're asking them to look up. So the cues are different. Can someone fact check me on that?
She's about to fact check.
Okay.
According to this, I think it's
The opposite.
cervical
Yeah.
retraction is just sort of making a neurofibrillation rather than a tuck actually.
Gotcha.
So the retraction, so if I have, come lie down on this stool right here. Most of the time when I'm addressing the neck, I start the patient out supine because it's easier to teach it. So retraction is more so of the chin moving posteriorly. So what you're gonna do, I'm gonna instruct him to press his occipital lobe into the pillow. So press your occipital lobe into the pillow. You see the movement? That is cervical retraction. So relax. Do that about 10 times for me. Okay. So this is your cervical retraction, and it engages your sternocleidomastoid muscles, which are important muscles as well, and also those rectus capitis posterior major and minor muscles, and engages those as well. So this would be a good supporting intervention to help improve subcranial backwards bending, but we're gonna get there once I show you all, Dr. McClure and I teach you all the manual therapy techniques. Now, the chin tuck is engaging those deep neck flexors as well, and you can use different things to show how much the person is engaging those, but we'll get to that as well. So chin tuck is asking a person, so he's not completing full cervical flexion, but he's just moving his chin towards the chest. That's it right there, and then come back. So that is a chin tuck. So chin tucks, often students and even us as therapists, we can get chin tucks confused with cervical retraction. They are different. So I have students ask me all the time. I have my patients do cervical retraction, and then I have my patients do chin tucks, which are two different things. And I've had students ask me, I thought, Dr. Carl, I thought they were the same thing, or they had them flip-flop, like how they explained it. But make sure you know the difference between those. So when you get someone with that deep neck flexor weakness, then you want to incorporate the chin tucks. Okay, you can incorporate cervical retraction as well, but your chin tucks are the go-to for those. I'm glad you pointed out those muscles. Recap those muscles again. Go back to that. You have to know this content. Now this you will see again.
But it was more the global muscles or the external flexors?
The deep flexors, the deep neck flexors.
Oh, longus colli, longus capitis, rectus capitis anterior, rectus capitis lateralis, more like multifidus rotators,
Yes.
and global muscles, which are more in the back.
Yes, so make sure that you know those deep neck flexors, because you will see that content again. They did a good job with their max, mod, and minimum protection phase. Go back to, go back to problem one. So problem one, max protection phase, posture education. So what are you gonna educate the patient on for posture?
How they're gonna stand up, how they're gonna be like sitting as well. We can ask about what type of job they do, because it's way different for someone that is in office that is standing up 7 to 8 hours.
Yes. So when I have patients who come with cervical problems, when they come to me with neck problems, and I ask them about their office setup, and I even ask them about their chair. If they have a chair with neck support, I instruct them in performing cervical retractions every 30 to 45 minutes. I say you may want to do about 10 to 15 cervical retractions, pressing the back of your head into the headrest, because you're sitting at the computer and your head is doing this over time. You go into a forward head posture and your shoulders are rounded. And that's what we typically do, even when we drive after prolonged driving. So even when I drive, I find myself like in a forward head position after a while of driving, especially when we take long trips, and I have to sit, make sure I correct my posture, sit back, and I do some cervical retractions. You know, sometimes when I do cervical retractions, I hear audible clicks, audible pops. I hear releases myself, because I've gone into that forward head posture.
Also, I read a news article, something like that, that if you were in an office, once you move your computer to eye level, that helps way more.
It does.
Once you're looking down.
Exactly. So when you say posture education or education, if you're gonna do that in your max protection phase, make sure that when you do your presentation, make sure you be specific on what you're gonna educate the patient on, because we need to hear that. We need to know, okay? So posture education is broad. Remember, this is for you all to be specific. So make sure you get specific. So good job on that. Global, all right. So strengthening of the global muscles. Perform shoulder blade squeezes. So good. So your shoulder blade squeezes are going to strengthen what? So you can say middle traps. What else? Run boards concentrically. So typically when I give patients to exercises, right? This is what I do. And it doesn't take long. I will show them the muscles on my iPad. I have a clinical iPad. And I show them the muscles. I'm like, these are the muscles that we're strengthening with this exercise. So go ahead and squeeze your shoulder blades for me. Good. And relax. I do things like this to get them feedback. I put my hand right here. I say, I should feel your shoulder blades coming to my hand. All right. And this is strengthening rhomboid minor and rhomboid major muscles. Okay. And so I explain that to them. So this, I'm just giving you the examples of what I want you to do in your demonstration. So I want you to be specific in what you're going to do. So you all said perform shoulder blade squeezes. Did y'all demonstrate those? Okay, all right. So make sure you talk about what muscle they're strengthening. Okay, make sure you inform your patient on what muscles they're strengthening. And you can even, if you want to, you can even go into detail how and why it's important. So these right here, you strengthen the run boards concentrically, but that's important because you don't want them to be too lengthened because that's gonna put the person in a rounded shoulder position. Then the pecs are gonna get tight. Then you have Vladimir Yonder, what they call muscle imbalances. You're gonna have muscle imbalances. I don't know if we went over that with y'all yet, but yes. Men protection phase. Patient returns to function, accurate head positioning, and movement control. So make sure you give some specific exercises that you're gonna do for that. I think y'all did. All right, good job. Problem 2. All right. Excellent. Keep going. It had pictures and visuals. Very good job. And so go ahead to the next one. All right. So go back. So in your men protection phase, I want everybody to think about this. With your intervention, think about how it relates to function. So remember, I gave the example in class, and I had the person doing diagonals. I just gave an example, and I had the person resisting against diagonals. So I could do the same thing with the TheraBand. So where's your TheraBand? All right. Take me, come sit right here. All right, turn your head to the right for me. Now, bend your head down as if you're looking down. Come back to neutral. This is a diagonal. Just go ahead and do 10 for me. I'll do 5. So now, I'm having the person to do this, and I'm gonna let my patient know this is functional for you to be able to look down and grab your coffee mug when you're driving, or like when you parked at a red light, you're able to look and actually grab that if you need to look down. Or if you need to look down to see something on the floor, you see how I'm in a diagonal, I'm looking down at a diagonal. This is very functional. So what I'm saying is, make sure that your men protection phase intervention, make sure you relate it to a function that is gonna be required for whatever movement that you're gonna be strengthening, or whatever muscle you're gonna do. And then we can do the same thing to the other side. Then we can turn around and do diagonals, backwards bending, so you feel that. So y'all see that? So I say, man, I may be at home looking, I leave the door open too long, mosquito gets in the house, I'm looking up, looking around for that mosquito. My wife is like, get that mosquito, you had the door open too long. Catch the mosquito, you know I don't like mosquitoes to bite me. So I'm looking, that's very functional, right? I'm not looking like this, just in the sagittal plane, right? I'm not looking up and down in the sagittal plane. I'm looking around, which my head, it has to move in a diagonal pattern. Does everyone get what I'm saying? So now you have to think about, how is this improving function? Because ultimately, we address the problems, which are the impairments, that improves functional limitation. Does that make sense? Because this is how you have to be thinking in the clinic. This is how you have to be thinking as clinician. All right? So make sure that you explain the functional limitation, because we're returning to whatever function, returning to prior level of function. Someone gets in a motor accident, they're not gonna be able to scan the room looking up to find that mosquito problem. That's probably gonna be difficult for them. All right? So, but excellent job, you all. I love how they incorporated in-text citations. What are the in-text citations? The superscript. The superscripts, because it's AMA. So AMA, the superscripts are the in-text citation. All right? and you go to, and then I can go to that reference list and see what references actually is, and I can go look up that reference through my ASU Media Center database. I can go find that reference and put my hand on that reference. That's how we should be doing. Good job.